Thank you so much, and once again, thank you, PK and the whole team for this very kind invitation. This open thrombectomy, is there a role, when and why? It's quite a very provocative question, especially for a surgeon. And just before Brian mentions that the thrombectomy devices are superior to the surgical options, not sure. Thus, I've got for this all no financial interest. Thus, in Europe, we have the European Society recommendations, and you see that when there is an acute limb ischemia, the patients need to be transferred to a center offering open and endo. Thus, there is still a room for the two technologies. And also, it needs to be to have a treatment in an hybrid theaters or an operating theaters with C-arm equipment. Thus, I mean that we have to deal with the two options. The flow chart, thus, again, we need to combine or to switch during the intervention one to the other technique, and only open and or endo, or to switch, or to mix, or to deal with the two technology, with the hybrid techniques. This is, we have to select the best treatments before and moreover during the treatment of all those acute limb ischemia. Open thrombectomy, is there a role? Yes, this is the recommendation, or you are mad or outside of the recommendations. Context, Ali is always an emergency, we all know that. The strategy employed will and always depend on a number of factors, including, of course, the expertise and the facilities of the treating team. Thus, this is really team depending. We all know that most of the Ali right now, it's coming from thrombotic event, and less percentage now of embolic event, and also some few popliteal aneurysm thrombosis. In Bordeaux, in our team, this is covering a very large area in the southwest of France. We use also the endovascular treatment, and we have used the first penumbra device. After we have used the lightning, and now we are using the bolt technology. This is very easy to use, it's efficient, but moreover on fresh thrombus, and we have seen the improvement in device during the last years. Disadvantage, this is very costly, it's not reimbursed in France, only for fresh thrombus, and it's time consuming. We also have the Rotarex, this is a case here. Again, it's efficient for fresh and mid-fresh thrombus. It's also very easy to use and to deploy. You see here the use of the Rotarex in the popliteal occlusion. It's quite time consuming, and that could be limited by the calcified and some stent lesion with some strut protrusion. And you see here the results after Rotarex device and after PTA. This endovascular devices in our team experience, this is mostly for thrombus aspiration in very, very right now selective cases and only limited to fresh thrombus. And moreover in association with adjunctive treatment like was PTA, stenting, and in some cases open surgery. It's quite costly and time consuming. The surgical thrombectomy is very easy to use, and in most of cases it's very efficient. That could be money saver. We practice it under general anesthesia. This is also in addition with surgical procedures to treat, in some cases, the inflow and in some other cases, the outflow. And also that could be in addition with endovascular treatments. Let's share with you what is very, very interesting. This is just an article in press, and we collaborate with this beautiful job. This is so-called the Promote Ali. This is in Europe, 36 European centers that have been combined to, this is multicentric, prospective, and observational study regarding all the Ali treated. Among 705 acute limb ischemia, open surgery predominated, followed by the endo only, and after the hybrid technology or procedures. There is a comparable one-day amputation-free survival rate. Completion of angiography for the open group minimize their interventions, but, and that needs to be underlined, the endovascular treatment had an higher reintervention rate and bleeding rates. Thus, in that wonderful multicentric job, that's where, regarding the embolic event, mostly they were treated by surgery and not by endovascular treatment. And that was the opposite for the occluded bypass and the occluded stent that were mostly treated by the endovascular treatments. And also the most and worst acute status were treated by surgery versus endovascular treatments. If we are focusing a little bit more what have been made in those centers, thus, you see for the open surgery, mostly this is only embolectomy. Very few cases endarterectomy. There are also remaining some prosthetic bypasses. And you see that there are also the completion of angiography only of half of those cases. Regarding not the hybrid, but regarding the endovascular treatment on the right side, PTA alone in almost 20% of cases, PTA plus stenting, 36%. Catheter embolectomy or aspiration, 32%, and mostly that was catheter-directed thrombolysis that have been used, and also some cases of atherectomy. And you see that any revascularization have been made neither by the open nor by the hybrid or the endovascular treatment in 4.2% of the cases. Thus, these are, and this is under publication, very robust data, again, so-called promotally. Thus, open surgery remains the predominant modality, particularly in arrhythmic, it means embolic patients, and those presented with severe acute ischemia. And open surgery is remaining the predominant modality. Thus, to summarize, open thrombectomy, is there a role, when and why? A role, yes, and it's still a predominant role. When? Maybe for the most acute limb ischemia, for the embolic lesion and associated in some cases with additional procedures. Why? Because this is efficient, fast, and less costly. Thus, there is still a place for the surgical option. Thank you for your attention.